Good afternoon, my name is Cynthia Atwell. Today we're going to be discussing anemia and polycythemia. Our objectives today on completion of this class is that you will be able to define anemia and polycythemia, identify the different types of anemia, name lab tests and values that are used to determine severity and types or causes of anemia, verbalize the signs and symptoms, clinical manifestations, and discuss different treatment options. Anemia is an extreme low count of the hemoglobin, hematocrit, and red blood cells. These cells are used to transport oxygen, and this results in a decrease in oxygen available to the rest of the body. Normal values may vary in athletes and elderly, people who live in high altitudes or smokers, and people who suffer from chronic disease such as heart failure or renal failure. A quick question: name two populations in which normal values may differ.
People that live at high elevations and smokers.
That's correct, thank you. There are 6 different types of anemia. There are chronic and acute hemorrhagic anemia caused from blood loss. Hemolytic anemia, which could be inherited or acquired. This is the breakdown of the cells. Iron deficiency or megaloblastic anemia, which is deficiencies of vitamin D and folic acid. And anemia of chronic disease, such as kidney failure. Excuse me. Hemorrhagic anemia. Chronic hemorrhagic anemia can be caused from gastrointestinal bleeds, or women who tend to have heavy menstrual cycles. It does not affect the blood volume, but it affects the iron stores and amount of hemoglobin that is available. Usually people who are affected by chronic hemolytic anemia are asymptomatic until they reach a hemoglobin level of less than 8 grams per deciliter. In acute hemorrhagic anemia, it is a very rapid onset of blood loss, and the body is unable to compensate for that loss. It can go into shock. It will make new blood cells, but they are not fully formed blood cells. There is a decreased red blood count and a release of immature cells. And when the bleed has been stopped, it can take up to 4 weeks in order for your blood volumes to come back to normal levels. Hemolytic anemias or premature destruction can be inherited, such as hereditary spherocytosis. This is a malformation of the red blood cells and where they become spherical or round and rigid. They still carry oxygen and they still perform their tasks until they reach the vasculature of the spleen. Once they get there, they are unable to form to the small areas like a normal blood cell, and they will rupture. Sickle cell disease is a disease that is is found in our black population. It is also a malformation of the red blood cells, but in this malformation, when they lose their oxygen, they become deoxygenated, they become very rigid and flat and form a sickle shape. This is an issue when it goes through the spleen. Again, it's destroyed because it can't conform and smush through those small areas like it's supposed to. And because of this, when it hits smaller vasculature in the outside of the body, it will clog up. It can cause pain and ischemia to those areas. It causes fingertips will be blue. The thing that we need to focus on the most would be pain management in the people who are experiencing a sickle cell crisis. We also can make sure that they are reoxygenated. When the red cells pull oxygen again, when they go past through the lungs, they will come back to normal shape, and make sure these patients are hydrated. Dehydration, change in elevation, sickness, these types of things can cause precipitate a sickle cell disease. Thalassemia is an inherited disease. It tends to be found more in a Mediterranean population. They have the correct volumes running through their system, but they manufacture fewer red blood cells and hemoglobin oxygen carrying capabilities. If it is a very light case, so to speak, usually there is no issues with those persons, but as they become more severe cases of thalassemia, they may require blood transfusion or even a stem cell transplant. Our focus on this population would be to teach them how to combat their fatigue, which is one of their major issues, exercise and diet. G6PD, glucose 6-phosphate dehydrogenase, is an enzyme that allows the red blood cells to function properly. When this enzyme is not available, the red blood cells tend to lyse. Acquired types of hemolytic anemias come from malaria. Malaria is a parasite that is transferred to the humans from a mosquito bite, and they reproduce inside the cell and cause the cell to burst prematurely. Drugs, chemicals, venoms that you may come in contact with can cause an exogenous type of lysis. Antibody-mediated types, such as a transfusion reaction, a blood transfusion reaction, will lyse not only the cells you've received, but the cells that you are making, the few that are there. Disseminated intravascular coagulation, renal disease, and I'm missing a word. Thrombocytopenic purpura also can cause this problem. Iron deficiency and megaloblastic anemias. The loss of iron with bleeding through hemorrhoids, cancer, menses, ulcers, polyps, gastrointestinal bleeds, and the increased requirement of iron through pregnancy can cause an iron deficient anemia. Dietary deficiencies, people that tend to practice strict vegetarian diets don't get enough vitamin B or folic acid. Alcoholics tend to not get these. Both of iron and the vitamin B are found in meat foods, and if the gastric mucosa is destroyed, you're unable to absorb vitamin B in the way you should. Folic acid are found in all of our vegetables, especially the leafy greens, fruits, cereals, and meats, but it's lost in heating, so we lose a lot of the stuff that's available when we cook everything. Malnutrition and, again, alcoholism decreases your ability to absorb these. Aplastic anemias result from the failure of bone marrow to produce red cells. Chemotherapy, radiation, other toxic drugs can cause this. Anemia of chronic disease such as infections, inflammation, rheumatoid arthritis, cancers, renal failure, heart failure, these things can cause anemia of chronic disease. Quick question, name 2 types of anemia and give an example of each.
Aplastic, which is like from chemo, and megaloblastic, which is folic acid.
Megaloblastic, yes, it comes from the lack of the deficiency of folic acid. Lab values. Complete blood count. Mostly what we're looking at are your red blood cells. These are your normal values for a male, 4.2 to 5.4 million per microliter, and for females it's 3.6 to 5.05 million per megaliter. Hemoglobin and hematocrit are a little bit higher in men. Ferritin, we want males to have no more than 300 nanograms per milliliter, and females no more than 200. Then your iron panels, we're looking at your serum iron, your total iron binding capacity, and your iron saturations. Viewing all of just these few from the many different types of labs that we can pull will tell us the severity of the type of the anemia and the type of the anemia. Clinical manifestations. When this patient comes to you and they talk about being tired, they talk about being weak, you notice their lips are blue or gray. You notice that they have a pale, waxy look to their skin. They complain of shortness of breath. They complain of chest pain. As you question them and assess them, you talk to them about their stools. People don't like to talk about poop. You got to ask them. But they talk about tarry, sticky type stools. History of weight loss, appetite, or night sweats. This could speak of an underlying issue that needs to be looked into further. Or if you notice that they have a yellow tinge to their skin from hemolytic type anemias where everything is just running around and it's not supposed to be. These are things we need to look for. Treatment options. Many times it's just educating. Teach them. Teach them how they need to eat, what they need to eat, how they can combat this on their own. Oral supplements are also available, either through prescription or over the counter. Folic acid, B12, iron. When these don't work, subcutaneous injections or intramuscular injections of B12 or erythropoiesis stimulating agents, epoetin, Procrit, darbepoetin. These help stimulate the production of red cells. When we get to a point that these don't work anymore, IV infusions of iron dextran or iron sucrose may help for the iron deficiency, and blood transfusions. When nothing else works, blood transfusions, and sometimes we can use the ESA agents along with it to help them get them back where they need to be. Name 3 clinical manifestations nurses should observe for on assessment or listen for on assessment to try to discern what might be going on.
Fatigue, chest pain, shortness of breath.
Yes, yes. Polycythemia. I threw this in there. It is not an anemia. It is an overabundance of red cells, but it is just as detrimental as anemia can be. It comes from neoplastic disease, your primary polycythemia. This is something that can't be fixed by changing some of your habits. More often found in men, causes increased viscosity of the blood. You have so many red cells in there, it's crowded, it makes your blood very thick. Causes splenomegaly because your spleen's working trying to get rid of this stuff and it can't work fast enough. Depletes your iron stores. You may notice they have blue tinged lips or fingernail beds. They complain of headache, dizziness, decreased vision or loss of hearing, and you may notice on assessment that they have a higher blood pressure. Secondary polycythemias are physiological problems. High altitude, people who live in high altitudes will have a higher count than we who live down here in the basins. Chronic heart and lung disease can cause this, and smoking is one of your major causes. Again, we will notice hypertension. They can have thrombosis, pain to joints. In our treatments, we watch their ferritin, and we want to try to keep that below 100 nanograms per milliliter. The ideal range is in between 25 and 75. Therapeutic phlebotomies. You pull a half a liter of blood off. You do this weekly to try to get them into a therapeutic range, and then once you've got them there and kept them there a little while, you can do a maintenance phlebotomy every month to 2 months. Low dose and aspirin hydroxyurea sometimes will help with this. About 50% of the population tends to respond, and low flow oxygen for the people who tend to have the chronic lung and heart issues. 4 facts regarding polycythemia.
It's too many red cells is what it is. It
Yes.
makes the oil too, I mean your oil too thick, your viscosity of your blood too thick.
Yeah.
And
What's one thing we can do to correct that?
pull a little blood out.
Mm-hmm.
And
Pull about a half a liter out.
you know, and let it just kind of thin out on its own.
What is the lab value we look for? There's one specific one we tend to look for with polycythemia.
Lab value. No.
Ferritin.
Ferritin.
Your ferritin levels. Ferritin is stores, and when you have an overabundance, it means that somewhere you're just producing too many. All right, I think that's 4. In summary, anemia is a disease of the red blood cells or hemoglobin and iron levels. It can be caused by a loss of volume, destruction of the cell, bone marrow failure, and nutritional deficiency. Anemia leads to hypoxia, weakness, shortness of breath, chest pain, decreased quality of life, shock, and even death if it's not corrected. Simple blood counts and clinical assessment is what we use to determine the diagnosis. Treatment is available ranging anywhere from changing your dietary habits and dietary education on our part to transfusions or other types of infusions and oral supplements. Polycythemia is an overabundance of red cells. It can cause joint pain and thrombosis, hypertension. We pull it off. We try to get them to stop smoking if that's the issue. And we use the same types of labs to determine this. Meet Ann Anemia. Ann is a 32-year-old mother of 2 active boys. She runs 2 miles a day every other day and is active in her boys' school. For the past 6 months, though, Ann has struggled to get out of bed in the morning. Her husband has noticed that her routine has changed and she's not running like she usually does. When she does run, she needs to take a nap in order to recover from it. On assessment, when she comes in, you notice that she is pale and has an excessive heart rate. She has a low blood pressure. What questions would you ask in order to complete your assessment to see what's going on with this young lady?
See if she's had any chemical treatments for aplastic type stuff. See if she's had heavy menstrual stuff for
Yes.
the hemorrhagic stuff.
Yeah, she's 32. That's probably a very good thing. The one thing that I want y'all to come away from here, if nothing else, is look and listen to your patients. Pay attention to them. These are simple little signs that we can watch for these diseases. Blue-tinged lips, pallor of the skin, shortness of breath, weakness, just saying they just don't feel good and don't know why. Talk to them, listen to them, and let the doctors know. I want to thank you.